If you're over 65 and your doctor recently celebrated getting your blood pressure down to 120/80, I need you to stop and watch this entire video because a major study tracking over 15,000 seniors found something that contradicts everything we've been told about blood pressure targets. The seniors who achieved that so-called perfect blood pressure number had a 28% higher risk of serious falls, higher rates of kidney injury, and here's the part that should have made national headlines, their mortality rates were actually worse than seniors with moderately higher numbers. I know that sounds impossible. I know it goes against everything you've heard, but stay with me because in the next 15 minutes, I'm going to show you exactly what the research says, why the standard target can be dangerous after a certain age, and what your blood pressure should actually be based on who you are, not just how old you are. I'm Dr. Sarah Ellison, and I've spent over a decade as a practicing cardiologist helping older adults protect their heart health and navigate the medications that are supposed to help them, but sometimes quietly cause harm. Today, I'm going to show you the exact blood pressure range associated with the longest survival in older adults, explain why the one-size-fits-all target your doctor may be using could be the wrong target for you, and teach you a simple 3-minute test you can do at home tonight that could literally prevent a life-changing fall. This is the conversation I wish more doctors were having with their patients. And if no one has had it with you yet, consider this your moment. Before we go any further, I want to ask you one quick thing. Drop a comment right now with just your age, nothing else, just your age. I want to see who's watching because the information I'm about to share applies very differently depending on whether you're 65, 75, or 85. And you've ever felt dizzy or lightheaded when standing up from a chair or getting out of bed, add the word dizzy to your comment. You'll understand exactly why that matters in just a few minutes. Let me paint you a picture that I've seen play out far too many times. A 78-year-old woman comes in for a routine checkup. Her blood pressure reads 144/86. Her doctor pulls up the standard guidelines, sees the target of below 130 systolic, and reaches for the prescription pad. One medication, then a second. Over the next few months, her blood pressure comes down beautifully, 122/76. Her doctor is pleased. She gets reassurance that everything looks great. And on paper, it does. But then something starts happening at home that nobody is tracking. Every time she stands up from the dinner table, the room tilts slightly. Every time she gets up at night to use the bathroom, there's a split second where she has to grab the wall. She mentions it at her next appointment and is told it's probably just age-related. Just stand up slowly, take your time. What's actually happening is that her blood pressure, which looks perfect sitting in the doctor's office at 122/76, is crashing to around 94/58 the moment she stands up. Her brain isn't getting enough blood. And one night, she reaches for the wall and misses. Fractured hip, emergency surgery, 3 weeks in rehabilitation, and the beginning of a loss of independence that, for too many seniors, never fully reverses. This is not a rare story. This happens every single day across the country. And what makes it so heartbreaking is that it is completely preventable if we understand that the target written in a guideline is not automatically the right target for every person over 65. To understand why this matters so much, you need a little bit of history. For decades, the standard cutoff for high blood pressure was 140/90. If you were above it, you had hypertension and needed treatment. If you were below it, you were fine. And for older adults, many doctors were even more lenient. A systolic of 150 or even 160 was considered acceptable because the thinking was that older arteries needed more pressure to push blood to the brain and kidneys. Then came the SPRINT trial in 2015, one of the largest blood pressure studies ever conducted, with over 9,000 participants, many of them over 75. The SPRINT trial compared two targets, below 140 systolic versus an aggressive below 120, and the results were striking. The group treated to below 120 had a 25% lower risk of major cardiovascular events, and a 27% lower risk of death from any cause. Those are significant numbers. And as a result, the American Heart Association updated its guidelines in 2017, lowering the threshold so that anything above 130 is now classified as hypertension. But here is what most people, including many doctors, don't fully appreciate about the SPRINT trial. It excluded people with diabetes. It excluded people who had a prior stroke. It excluded frail seniors and people in nursing homes. And critically, blood pressure in that study was measured under ideal controlled conditions. Patients sitting alone for 5 minutes, no white coat in the room, which typically reads 10 to 15 points lower than a standard office measurement. So the 120 target in SPRINT may actually correspond to closer to 130 or 135 in a typical doctor's office. Applying that trial's conclusions to every older adult across the board is where things start to go wrong. Here's what the SPRINT trial couldn't fully account for: the fundamental ways your cardiovascular system changes as you age, and why those changes mean the numbers need to be interpreted differently. The first change is arterial stiffness. As you get older, your arteries naturally lose elasticity. Think of a brand new garden hose versus one that's been sitting out in the sun for 20 years. The old hose is rigid. It doesn't flex and absorb pressure the way it used to. Your arteries go through a similar process. And when your heart pumps blood into stiff arteries, they can't expand and cushion that pressure wave the way younger arteries can. This means your body actually needs a slightly higher baseline pressure to ensure blood reaches your brain and kidneys, especially when you're standing upright and blood has to travel against gravity. The second change is slower baroreceptor response. Baroreceptors are tiny pressure sensors built into your blood vessels. In a young person, when you stand up, these sensors detect the pressure drop almost instantly and signal the heart to compensate. Heart rate increases, blood vessels tighten, pressure stabilizes. In older adults, these sensors slow down. They respond sluggishly. So if your baseline blood pressure is already sitting low because of medications, and then you stand up, there's a dangerous window where your brain simply isn't compensating. Getting enough blood flow. That's the dizziness. That's the grab for the wall. The third change is how your body processes medication. Your kidneys and liver don't clear medications as efficiently at 75 as they did at 50. A dose that's perfectly calibrated for a middle-aged person can linger in an older adult system longer, produce stronger effects, and push blood pressure lower than intended. This is why medication management in seniors is not just about the right drug. It's about the right dose for a body that metabolizes things differently than it used to. These three changes together paint a clear picture. Treating a 78-year-old's blood pressure the same way you'd treat a 48-year-old's is not precision medicine. It's a mismatch, and in too many cases, a dangerous one. So what does the research actually say about the ideal range? A landmark study published in JAMA Internal Medicine followed 15,342 adults over the age of 75 for an average of 5 years. And these weren't cherry-picked healthy seniors. These were real-world older adults, including people with diabetes, prior strokes, heart disease, and varying levels of frailty. Researchers divided them into groups based on their average systolic blood pressure and tracked what happened over those 5 years. Here's what they found. The group with the lowest mortality rate, the group that lived longest and stayed healthiest, was not the group with blood pressure below 120. It was the group with systolic pressure between 130 to 140. The group that achieved that textbook perfect below 120 reading had a 28% increased risk of serious falls requiring hospitalization, higher rates of acute kidney injury, and a 14% higher overall mortality rate compared to the 130 to 140 group. The group above 150 also had problems: more strokes, more cardiovascular events, as you'd expect. But the key finding, the finding that changes everything, is that very low blood pressure was just as dangerous as very high blood pressure. The sweet spot for seniors is not at the bottom of the chart. It's in the middle. This is the dual danger that doesn't get talked about enough. On one end, chronically high blood pressure, above 150, is the silent killer you've heard about. Most people feel nothing, no symptoms, no warning. But inside, the constant excess pressure is quietly damaging artery walls, straining the heart muscle, narrowing blood vessels in the brain, and setting the stage for stroke, heart failure, and kidney disease over years and decades. But on the other end, blood pressure that is pushed too low, especially through aggressive medication, creates its own set of dangers. Falls and fractures, orthostatic hypotension, that dangerous drop when you stand up, episodes of reduced blood flow to the brain that can accelerate cognitive decline. And in people with coronary artery disease, very low diastolic pressure can actually reduce blood supply to the heart muscle itself during the resting phase between beats. So if your doctor is focused only on the number in the chair and not on how your body responds when you're actually living your life, standing, walking, getting up at night, then an important part of the picture is being missed. Which brings me to something I consider one of the most important and underused tools in blood pressure management. And you can do it tonight with a basic blood pressure monitor that costs about $30 at any pharmacy. It's called an orthostatic blood pressure measurement, and it tells you something your doctor's office reading cannot: how your blood pressure behaves when you actually stand up. Here's exactly how to do it. First, lie flat on your bed or couch and rest for 5 full minutes. Don't skip this step. The resting period matters. After 5 minutes, take your blood pressure while still lying down and write down both numbers. Now, stand up and take your blood pressure again immediately, within about 30 seconds of standing. Write those numbers down too. Now compare. If your systolic, that top number, dropped by more than 20 points when you stood up, or if your diastolic dropped by more than 10 points, that is a clinically significant finding. It's called orthostatic hypotension, and it means your blood pressure medications may be stronger than your body can safely handle in real-world conditions. Even if your sitting reading looks perfect on paper, a 25-point drop when you stand means your brain is running on insufficient pressure for much of your waking day. That is a fall waiting to happen. And when you bring those numbers to your next doctor's appointment, you'll be having a very different and much more productive conversation. So what should your blood pressure actually be? Let me give you the ranges that current research supports, and I want to be clear that these are evidence-based starting points, not personal prescriptions. Your individual target should always be worked out in collaboration with your own doctor. For adults aged 65 to 74 who are generally healthy and active with no major conditions, a systolic range of 130 to 140 is well supported by the research. This provides meaningful cardiovascular protection while keeping the risk of orthostatic drops manageable. For adults aged 75 to 84 who are relatively healthy, the evidence supports a slightly higher range, 135 to 145 systolic. That upward shift accounts for the arterial stiffness and slower Barham responses I described earlier. For adults over 85, or for anyone at any age who is frail or has a history of falls, a systolic range of 140 to 150 may actually be the safest target. At this stage, maintaining quality of life and preventing catastrophic falls often needs to take priority over aggressive pressure reduction. And on the diastolic side, that bottom number, research suggests it should generally stay above 65, ideally between 70 and 85. A consistently low diastolic, particularly below 60, reduces blood flow to the heart muscle during the resting phase and can be just as concerning as a high systolic. To make this concrete, consider two patients, both 81 years old, both with a reading of 158 over 88. The first has mild heart failure, chronic kidney disease, and osteoarthritis. Aggressively pushing her blood pressure below 130 with multiple medications could worsen her kidney function, cause orthostatic drops, and dramatically increase her fall risk. For her, a gentler approach, perhaps one low-dose medication targeting 140 to 145, is more appropriate. The second patient is healthy, active, plays golf twice a week, and has no significant medical history. For him, treatment may be warranted, but even then, the goal might be to bring it down gradually to 145 with lifestyle changes first before adding medication. Same number, same age, completely different approach. That is what individualized medicine looks like. Here's what I want you to do starting tonight. First, if you're over 65 and on blood pressure medication, get a home blood pressure monitor if you don't already have one. Take your reading at the same time each morning and evening for 2 weeks. Write it down. Patterns are more meaningful than single readings. Second, perform the orthostatic test I just walked you through, lying down, then standing. Note any drop above 20 points systolic or 10 points diastolic. That is information your doctor needs to see. Third, pay attention to your symptoms. Dizziness when standing, unexplained fatigue, difficulty concentrating, feeling foggy. These can all be signs that your blood pressure is being pushed too low, even when the number in the chair looks fine. Fourth, bring your log to your next appointment and ask a specific question. Given my age and overall health, what blood pressure target is right for me and why? Don't accept a generic answer. You deserve a specific one. Fifth, if you're experiencing side effects, dizziness, fatigue, feeling off, say something. Many people assume this is just what aging feels like. Often it isn't. Often it's a medication dose or target that can be adjusted, and quality of life can be significantly improved with one honest conversation. The most important thing you've learned today is this: blood pressure targets are not one size fits all. For older adults, especially those over 75, a systolic reading between 130 and 145 is associated with the best survival and quality of life. Below 120 carries its own serious risks. Above 150 carries risks too. The sweet spot is in the middle, and where exactly in that middle you belong depends on your age, your health history, and how your body actually responds, not just how it looks sitting still in a chair. You've also learned that orthostatic hypotension, that drop when you stand, is often more dangerous than the number your doctor is treating. And now you know how to test for it yourself. You are no longer just a recipient of medical advice. You're an informed participant in your own care. And that changes everything. If this video gave you clarity, drop a comment saying informed. I want to see how many of you are walking away with this understanding. Share this with someone you love who is over 65 and on blood pressure medications. They need to see this. And subscribe to this channel because every week I bring you research-backed information on the heart health topics that matter most to seniors, delivered clearly, practically, and honestly. I am your doctor, Sarah Ellison, and I will see you in the next video.